Hello and welcome back to Femcast. My name's Lawrence Hill and I'm one of the module team delivering these modules specialising in Fem in collaboration with the East Anglian Air Ambulance.
Hi, I'm Rob Major. I'm one of the Deputy Medical Directors at EAAA and I co-host these podcasts with Lawrence.
So today, Rob, we're joined by Dee Mencarini. Say hello, Dee.
Hello, Dee.
Tell us about what you do.
I am a hazardous area response team paramedic. I'm located down at the Essex base for East of England Ambulance Service.
Brilliant. Thank you. Because in this particular episode, we're talking about all things hazardous area response, CBR, hazmat and all of that kind of stuff. So absolutely brilliant to have you with us, Dee. Thank you so much.
Thanks for having me.
Nice, great. So we'll get straight into it, I think, today, if that's okay. So if you could tell us, maybe just tell us a little bit, first of all, about how you ended up doing what you do before we get into the questions.
So I graduated as a paramedic in 2017 and I got some experience of frontline operations under my belt. And I think that it's good to change things up every so often. And after about 3 years, I felt like I needed something new. And so I applied for the hazardous area response team and didn't get an interview. And then sometimes I think when you don't get something, it makes you realise how much you really wanted it. But I think it's fair to say I was quite naive when I did my subsequent application and then I did get through. And then I realised it was actually really hard work. And there was a lot of residential courses to go through the training. And so I think any HART paramedic that you ever meet, they'll have this understanding between each other of the training that they've gone through to get there. So it's expanded my knowledge of all these different competencies that we have to be trained in, and that on top of being a paramedic. So it really layers things up. So it's not just about going in and doing an assessment, but going in and keeping yourself safe and your team safe, etc. With all of these different types of what keeps me safe working at height, what keeps me safe in a confined space, what keeps me safe in water. And so it was a challenge. So that challenge I was looking for was probably tenfold than what I realised when I actually applied. But I love it, and it's great fun, and there's always so much training to do. So that's how I got there.
Interesting. I would love to hear a bit more about some of that. But I think one of the things that kind of indicated to me that there's layers underneath it is just that there's all of those drugs in the JR calc that paramedics don't give. Your dicobalt, editate, and all of this sort of like really kind of exotic looking kind of names for these sort of obviously drugs that are used in really nasty situations. But yeah, you have to train to use all of those, and then all of the other hazardous area stuff that you have to think about.
That's true. I think the dicobalt, editate, that kind of thing I can't remember what poisoning that is actually. I think it's been removed. Yeah, I think it's actually been removed. And
is it? Right.
I only found that out in the last 2 days.
Yeah.
But you're right, there are layers. I think that it's important to remember that with the initial response, so we're going to be just bringing paramedic skills into those hazardous environments. So we're something between, if you didn't need those skills, you could send firefighters in as they used to do. And that's the point of a hazardous area response team. So if interventions weren't required, we wouldn't be needed. Yeah. But I think it has been recognised that if we can get some practitioners in there to deliver those skills, it could subsequently mean more lives will be saved, or, less morbidity at least. Yeah. And that depends on the incident. And we were created from the back of the 7/7 attacks. And that was what the inquiry recognised, that something else needs to be in those zones. Yeah. And obviously it's not safe for frontline operations to go in there. And we wouldn't expect people to risk their own lives in order to do that. So just if you're willing to take the risk and you're willing to go through the training, then that's how you do it.
And a lot of the time, I guess the teams are spread out, aren't they? Quite a lot. So you'll have a HART base in Essex, and there'll be one in Cambridgeshire and stuff. But I guess in a lot of these scenarios, you won't be first on scene, will you? You'll be coming in support Maybe,
Very much so. It's really, really rare to be first on scene to anything. And usually we're requested by the frontline operations crew, which is really interesting because it goes from being first on scene and assessing is it safe and doing your primary survey to, hi guys, what can I help you with?
Yeah.
What do you need? And that's a really nice switch, actually.
Yeah.
It's a really nice way of, you trust that they've done an assessment. You bring a fresh pair of eyes at times that, have you considered this, or why don't we try this? And actually sharing your knowledge of, we've done these difficult extrications so many times. This is a technique that usually works for us, and that's a really nice way to share it. And it's often received well.
Yeah. And a lot of the stuff you do is the stuff that's been in the press recently has all been sort of around chem stuff. I mean, it's all been in the, all the Skirple stuff and everything. How do you find sort of the maybe not your response, but how do you find the sort of the first response and the wider knowledge? It's something that we don't come across very often. We look at it from HEM's perspective, but we don't come across it very often either. And a post-grad road paramedic isn't going to come across these things at all. So how are they, I know they get a little bit of training, but it's probably tiny. How are they identifying these things? How do you find scenes and stuff? Or when you do training, when you arrive, and sort of what state can it be in, like the incident when you get there? Because obviously you're looking at other people's safety, not just your own, I guess.
That's right. Yeah. So I think it's really difficult sometimes to identify things such as hazardous substances. So usually that might be picked up at the call handler point.
Okay,
and so the calls are all scanned by incident command desk. And so if something looks a little bit suspicious, then it will come straight to us. It's one of our, like yourself, in HEMS you have those, that's definitely a helicopter job. Similarly, we'll have, that's definitely a HART job.
Right.
And so then the dispatcher will liaise with the team leader, have a discussion and ask. But I think in terms of identifying that as a frontline operations crew, that you're right, there is a little bit of training. And I think that most people will be familiar with steps 1, 2, 3. So safety triggers for emergency personnel 1, 2 and 3. So if one person's on the floor, approach as normal. If 2 people, be cautious. If 3, don't go there. But that's been replaced now, and I'm not sure that everybody would know that yet. But now we have a different thing that's in place of that, which is recognise, assess and react, so RAR. So the recognition can come right from the call handler. So if something sounds a little bit off, like there's a couple of people, and I remember when I was a frontline paramedic, there was a call that came in, and it was outside, it was late at night, and there was 2 people on the floor, and I was like, we can't go anywhere near that because there's 2 people on the floor. We better, we need to interrogate this call a little bit more. But I think that that's often something that people will think about, how many people were down. That will give them an indication of suspicion. However, one of the more frequent things that people might see is an individual chemical incident. So perhaps chemical suicide or that kind of thing. And there's indicators at the scene that might identify those things. But the call handler, if they get a call that says, someone has posted pictures on their windows to say do not enter or call police or that kind of thing, they're indicators. And that's where it would start to rise that suspicion, and it would probably come to us. So it is difficult.
So that's the recognised bit.
That's the recognised bit, and that starts from call handler, and then it gets interrogated all the way down. So I think if I was going to advise crews, it would be, so if something doesn't feel right about it, if there's something that is like making your hackles go up, then probably just interrogate the call a little bit further. And if there's any mention of chemicals, if you're at a factory or thinking about the environment and where this call has come in, in individual chemical incidents, a car parked at a lovely scene, perhaps the sunset or the sunrise, alone in isolation, I probably wouldn't be opening that car door. So I think that there's like a little bit of a hunch of what that might be. But you're right, if you're not exposed to that, or if you're not trained in that all the time, then I guess it's easy, if you add lots on, people have enough to think about in terms of maintaining their practice and what they go to regularly. having this index of suspicion, you don't have a lot of room for it. But I guess that's, you know.
That's why you have specialist teams.
Yeah.
So, but yeah, and so that's that. So let's put it in like a context then. If there were to be like a powerful chemical involved at an incident, let's say like a chlorine leak as an example we were talking about beforehand, like a massive chlorine leak at a swimming pool, there's going to be presumably lots of agencies involved. How, as a clinician, as a heart clinician, do you go about organising such a difficult and complex scene?
So I think that one of the things that HART are really good at and are required to be really good at is multi-agency working. And so that call would have been, you know, recognised, and the assessment of who, what, where, when, that why do you think this is a problem, etc. That would come through, and as I say, that would be interrogated by the team leader. So that would decide what kind of response that needs, and quite often, if there's a suspicion that you're going to need some sort of PPE, depending on what it is, a lot of this is it depends. Yeah. Depending on what level of PPE you might need, the team leader will recognise that there will be a requirement for a safe system of work, so they will allocate however many people in the team that they might need. They might request additional resources from, you know, luckily in the east of England we have 2 bases, but often HART teams only have 1. So you might need to request mutual aid if the incident is such that you will need more members of personnel. And then as we arrive on scene, there will be, the team leader will probably go into a JESIP meeting and use that joint decision model to decide what is required, what's there already. So at a chemical incident, you would absolutely expect fire and rescue service to be there, possibly police as well. So there would be regular JESIP meetings so they could all liaise with each other, sort of at an operational level. And there's a lot of that. It depends. Depending on the incident, it might be a requirement that a National Interoperability Liaison Officer, a NILO, is involved. So possibly advice will be sought via the NILO as well, especially in chemicals and stuff like that. Being able to identify what kind of chemicals could be involved. So there's a lot of sort of action cards specifically for certain events that they would follow. And then, you know, depending on how that meeting goes and what's required, what's necessary, how many patients there are, etc., there will be, then the team leader will recruit with their team and they will give us an II March brief, which will dictate how we're going to go about whatever it is that we've been asked to do. So that would be covered by the intention and then etc. So iMarch is just a way to organise an incident, and so that all of the team members understand what's going to happen.
Yeah, it's that shared awareness, I guess, isn't it? Situational awareness and all that stuff. Yeah. That's really interesting. I mean, it's a good example of a chlorine chem attack, because, you know, there have been those within the east of England before, and you know, they're fairly common, aren't they? So what kind of, you talked about PPE. I know you can't talk about all of your PPE, but in terms of chem stuff, you obviously have different levels of PPE, and we're used to PPE in COVID, aren't we? So tell us a bit about the PPE and from sort of top to bottom that you guys might carry for a chemical incident.
Okay, so for a chemical incident, I think that, again, it depends. Yeah. If the chemical has been identified... That's going to be
your golden nugget, isn't it? Your golden nugget is going to be... Well, it depends.
Well, it depends.
But it does, though. It does. To make light of it, but of course it does. And that's part of operating in, you know, a dynamic, austere and often hostile, I suppose, chemically, biologically or whatever. It does depend on a whole host of different factors that are beyond the kind of consideration a lot of the time of regular roadie paramedics like me. Sure.
And I think... you know, the things that it depends on is, the big one is, do we know what the substance is?
Yeah.
If we don't know what the substance is, we go right to the top, and we're going to use our highest level of PPE for chemicals, which would be a gas-tight suit.
Yeah.
So that is, it does what it says
It's
on
like
the
a
tin.
Teletubby outfit, isn't it?
It is like a Teletubby
Spaceman,
what it
outfit.
looks
Spaceman
like to
kind of,
me.
yeah.
It's a bit like that film Monsters Inc. when they
Yes.
go 2319
Yeah.
and everybody rushes in suits. That's us. And so underneath the suit, let's start with what we've got on. So we have our ground kit, incident ground kit on. We can't wear shoes with that because it has integrated boots. So you'd have your incident ground kit, and then you would have your breathing apparatus wear. So we use extended duration breathing apparatus, so dual cylinders to enable us to be in a respirable environment no matter where we are. But if we don't know what the chemical is, we don't know whether that's going to have an effect on us, on our skin, etc. So to double down with the safety, not only do we then have respiratory protection, but then we will then also go into a Teletubby suit or a gas tight suit and get zipped up. So that is quite difficult because you can't get into that on your own. So you have to have a buddy and you have to have lots of buddy checks. And there's a time limit. You can only stay in that suit because of the physiological stress that can cause. It's hot in there. It's very claustrophobic. You have to be super comfortable with being in a really, really small space. And once you're zipped in, if you're going to go forward into that area, and of course that's going to have an effect on the way you assess people. If you are in what is effectively a massive rubber glove, you can't feel for a pulse when you've got a gas tight suit on. But you use different techniques of how to assess patients. So it again, like you are well versed in being able to conduct a primary survey, but if you take away some of those abilities of being able to, you can't really see very well because you have not only your gas tight, your breathing apparatus mask, but you also have the gas tight, and that fogs up because you're getting really hot.
Well, of course, because you're carrying how many kilos of
23 kilos on your back.
23 kilos on your back.
Yeah.
And then the suit itself has got to weigh
It's about 15, yeah.
So, I mean, you've got to be pretty fit.
You do have to be quite fit. And so, obviously, you're working hard. The breathing doesn't matter. That doesn't fog it up. But you're sweating. And so you end up having to take out an arm from one of your sleeves and giving your little window a little clean and then going back out. So your visibility is really quite poor.
Yeah, I can imagine.
You can't really hear either. So you have your noisy Darth Vader breathing apparatus, and you have a radio in there, but you have to pull out your arm from your thing to be able to answer the radio. So comms are really, really difficult. So hand signals are really important. So different ways of communication is really important. Add that on also, because you've got breathing apparatus on, you have to check how much air you've got. Am I gonna go to my whistle and have to get out of this and quickly evacuate because I'm gonna run out of air or need some supplementary air from someone else? So you've got your gauge checks and you need to check your air for your own safety. So that's something else. So we're talking about CRM. You have to have that awareness, and you're making sure that you always have to work in pairs. So you're going to make sure that your crewmate is also in the line of sight, so they don't, if they topple down, that you can make others aware. So then all of your senses are changed. You can't see so well. You certainly can't hear very well. And then you go and be a paramedic. So that's like a high level.
Much more of your mental processing, rather than be focused on the patient, is focused on you, safety, your buddy. So you have much less, don't you, I guess, to then deliver in terms of, you're still expected to then provide that complex decision making and all of that stuff, and some treatment. And providing treatment must be really hard as well.
And what also depends is how many patients there are.
Of course,
So in that sort of situation, then you would quite often, if you're in that level of PPE at a large incident like a leak or whatever, it depends on how many people you've got to assess. So you'll go to a triage system. And again, most people are familiar with triage, but the assessment is slightly different for CBRN. There's certain things that you just can't, and it depends on the numbers of casualties that might be there. So I mean, we're talking about that's the highest level, most difficult, whereas other levels of PPE will be much easier. So if the chemical is identified and then the team leader makes the decision, or the NILO and the team leader or whoever is involved in that decision-making process, luckily not me, I'm not paid enough to make those decisions. If they want to downgrade to something like PRPS, visibility is easier.
Yeah.
You can hear a lot better.
What's PRPS?
I was hoping you wouldn't ask me that.
It's a level down on the PPE.
So it's a respiratory suit, so it blows air in, and you have your filters.
It's like we had them in COVID. It's like a hood with a filter pump, but it doesn't have to be sort of chemical tight, does it?
No. It's so you have your activated charcoal filters that will filter the surrounding air and into you. So it's a bit cooler. Not much, but it is a bit cooler. But it is a full body suit.
Yeah.
And
then
again,
you're not in BA.
You're not in BA for that.
So big difference there.
And that is where our specialist operations response teams, so in addition to the hazardous area response team that will have that high level PPE go in, assess casualties, and depending on what our team leader has said, it will either be, treat and take or treat and leave or whatever. The SORT teams, the specialist operation response teams, will be putting up decontamination tents. And so they have a level of care that they can provide, but there will, once you have been given your brief of what you're going to do, if it's a chemical incident, what you're going to do is remove. You'll remove them from the chemical, you will remove their clothes, you will remove gross contamination, and you will take them then to the decontamination area where PPE would have been downgraded, and you can have lots and lots of people in the SORT team who can then help to decontaminate, or you'll have fire that will set up a quick decon.
Of course, people who aren't walking.
Maybe not. Maybe.
So on top of 23 kilos of BA, 15 kilos of suit, you've then got whatever the patient weighs on top of that.
Yeah.
The nutritional overachievers.
It sounds like a really good workout. Yeah.
Come along.
I'd love to. Yeah, no, if that's an invitation, I'm there.
Yeah.
So clearly you are operating in some of these environments or potentially operating in these environments which are really difficult and dangerous. And you've got the right stuff to make sure that you're protected in those environments. But what can non-CBR trained practitioners do to try and keep themselves safe at a CBR site?
Okay, so if it's been established as a CBR site already, there will be cordons in place to keep those responders safe. So you would say, HART might be in the hot zone. To simplify it really, really quickly, HART might be in the hot zone, SORT will be in the warm zone. And then once they've deconned those patients who may well be walking, but they might not, then they will go to the clean area, the cold zone, and that's where frontline ambulance will be responding from, and it will be taking the casualties as and when. If they arrive on scene and they don't know or they're suspicious about it, and it smells a bit funny, I'm not sure, shut your cab windows, turn your ventilators off, and move upwind of the incident, and to make sure that you're, most of us have that sense of I don't like this. If you get called to somewhere, it's like white powder at a post office, you're not going to go anywhere near it, hopefully. But you would certainly stay upwind and uphill of an incident that you're thinking, because, gases and chemicals, they have different weights. Some of them are lighter, they move around differently, and that's something we have to learn about. We have to be conscientious of kicking certain things up depending on the incident that we're at. If we've got heavier chemicals and gases, they're going to be lower, and us disturbing it is going to cause problems. So but in the absence of knowing any of that, I think that the best thing is just to stay well away and communicate your concerns to control, and just say, I don't like this, and just to interrogate things a little bit more if something doesn't feel right. And certainly if there's multiple people that are unwell, I wouldn't be going anywhere near it. I'd say, I don't have the PPE for this. Yeah,
it's really difficult, isn't it? For I'm thinking to cases as well. It's really difficult to not rush in and treat patients, isn't it? But it's really important to take that time to just stop and think. well, show my age. The Condor moment, you remember the Condor cigars that used to be advertised on TV?
Sorry, mate.
No, it's a Condor moment,
Lost on
right?
me.
Where you have your cigar and you wait a bit and you make some critical decisions, but you don't. It's that first rule of triage, isn't it? Just don't run in. You need to have your operational Jessup base. You need to communicate and you need to start that process in an organised way. And that must be really difficult, especially when you're seeing people dotted around on the floor who may be really obviously in need of help. And again, that's a multi-agency thing, isn't it? You know, so it's. Having been at some of these incidents before, it's very difficult to overcome the psychological urge of people who are used to caring for patients to just run in. And when it's a risk to them, that can be really difficult.
Sometimes it's really, really difficult because at the end of the day, in pre-hospital care, we're all there to do the same thing. And so to pull people back is really, really tricky, because especially if, say, for example, it was a critical care member of personnel. They know what they need and they know that they can deliver it, but they're putting themselves at risk. We were talking about this recently with trench work and all the risks that come around that type of confined space. And it looks all right. I can see them. I could easily just go and help. I know what they need. They could really do with like some really good pain relief if I just reach in. But it's just not worth the risk. It's very difficult to sensitively pull people away. Just say, hey, you don't really have the PPE for this and you're going to put yourself in danger. And at worst, we've got more casualties and we've lost our specialist ability to treat them effectively. So I think it's a really tricky balance.
Humans aren't very good at judging risk at the best of times.
No.
And like if you can see the person and they're in a trench, and presumably what you're concerned about there is that there's some low-lying kind of chemical or gas that you can't see, but you can see the patient.
Certainly.
And you know that you can just
if it hasn't been shored effectively. And there's different types of collapses.
See, I hadn't even thought about the fact that it might fall in. All I'm thinking is, we could do something about this.
You'd have been buried.
I'd have been buried and asphyxiated.
One cube meter of mud is 1,600, like a ton and a half,
right,
on your chest. So you're gonna get a crush injury.
You're finished, aren't you?
Yeah.
And there's loads of different types of collapses which we need to know about. No one else needs to. They just need to listen if we say, just come away from there. Because we wouldn't be saying it for any other reason than to keep them safe. That's it.
Yeah. And I think that is perhaps sometimes the kind of the sense that non-HART practitioners have of HART. Like, it's a bit like,
they want to come in and take over. It's not that.
It's your special sixth sense for risk, is it? Yeah, I can see what the problem is. Let me address it.
It's just training, though, isn't it?
Yeah, of course.
That's all it is. It's just we might just see risks that you wouldn't
be aware
to consider
of. The unknown
in your life.
Yeah.
It's really interesting, the psychological element, because in some of the large terror major incidents in London, there are members of the public who ended up with patients who are really badly injured and who were effectively dying while the terror incident was going on around them. And they were shouted at by the armed police to get out of there, but they refused to leave. They didn't know these people, but they refused to leave patients. So they just become at risk themselves, even though they weren't injured, but they refused to leave. It's that human element, isn't it? So you can't spend half an hour trying to get one person to leave scene. You've got a bigger job to do. You tell them once directly, and then you just have to move on and accept it.
Absolutely.
But the human element of it can make scenes really complicated. And we see that at critical incident scenes, which aren't anything to do with hazardous areas, where we're asking people to either move away or give us space or do X, Y, and Z, and it's the same at any scene, isn't it? That's a human resources challenge. Especially if you've got friends or whatever, and there's alcohol and all that stuff. It becomes really a challenge.
And no one wants to put anyone's nose out joint.
No,
that's the last thing. We just want to make sure that everybody is safe. And we've all been there at possibly a public cardiac arrest, and police are doing CPR, and you're like, I think we need to swap you out. No, I'm fine.
Yeah.
It's not about you being fine. It's about giving effective CPR. And sometimes there's just another level of why we're doing it. And I think
you haven't got the time to explain it.
Not always.
Or deliver the training
you need
needed.
to be doing this at 100 to 120. And you're not wearing any gloves and etc. But I think making sure that you communicate that sensitively so that the person receiving that information doesn't feel like you don't think they're doing a good job. That's the most important thing. And I think that's very dependent on the individual's approach of how do I sensitively move you away from your own danger that you're unaware of.
The whole module is around that concept, isn't it? Around human factors and
Crew
around team
resource
working
management
and all that stuff. And it's when the risk to healthcare workers or the wider public or whatever is increased, because a lot of scenes there is not a lot of risk to the public. There can be, but in a lot of scenes, you're in someone's front room and they've had a cardiac arrest. Actually, it's probably all right, isn't it? But actually, when that level is raised, a lot of the time the clinicians won't see it or won't recognise it, and that's the benefit of having other people around to look after everyone, right? So
there's moments to become really task focused, and there's moments to have that situational awareness. And I think that one of the benefits, as I said right early on, is going in with a fresh set of eyes is really, really helpful, of being able to take in everything about the scene and just having a different perspective. Coming in new isn't I know anything more than you. Clinically, it is I can just see where you're so task focused, and that's okay while you're doing an airway. Do that. But you need to do this, you need to move away from there, that kind of thing. I think that's a really important point.
Superb. Okay, so you've talked a little bit about some of the challenges of assessing patients when you're wearing those all of that PPE that you have to wear. And then you mentioned about how they'll go to the SORT areas and they'll go to decon. After that, what kind of special considerations do you need to have in terms of the ongoing care and management of patients who have got some kind of chemical, biological, radiological injury?
I think that that would be discussed at a strategic level. So depending on what it is, it depends. And the NILO would facilitate those conversations with the hospitals, etc. So we're not going to put someone in a situation, say for example a patient is off gassing, we're not going to stick them in an ambulance with road staff who just have a normal surgical mask. There's going to be considerations.
When you say off gassing, sorry, can you just explain what you mean to me?
So gas is coming off of their person, and sometimes that might be...
Oh, I see. So like literally stuff that's like chemicals attached to them that's actively producing vapours that's... Right.
Yeah, and sometimes that will happen with the deceased, and we have specialist CBRN body bags, which have filters on the inside, so that when they off gas, as people do, it doesn't cause any danger to wherever they're going to go, more than likely the morgue. So that's another thing that HART will do. It's actually the police's responsibility, but we'll help to do that. And so conversations will happen with the hospitals, and the hospitals have a response ready. They have PRPS capability as well, so a level of PPE for decontamination. So that would be arranged via the NILO. They will make the hospitals aware of what's coming. Hopefully by that time you would know what it was. And considering that chemicals are poisons, that is one of those situations where you don't stop a resuscitation effort, and that's where it gets really, really tricky. Because if I need all of this PPE on to be around you, and you have ingested, absorbed, inhaled that, your chances of survival are so slim. But because it's poison, and it's one of our reasons to not terminate a resuscitation,
that's tricky.
You're going to have to keep going until someone says, stop it now.
Right. And whose decision is that?
I think it's got to be a doctor that's paid quite a lot of money.
I don't know any of those.
It would be a high-level medical director, that kind of thing.
A med director type decision.
We'll just keep going in that, 50 kilos until somebody says, stop.
And there is a whole load of stuff around poisoning. I mean, poisons are, although people can be in cardiac arrest for long periods of time, they're, obviously people take, medications for self-harm and suicide, and actually that you can get really good outcomes, and there's a whole load of additional bits and pieces you can do. And a lot of it is not public knowledge. There may or may not be a public inquiry, but the learning around the Skerpals and the Novichok stuff in hospital, and all of the stuff that went around understanding and looking after them with a chemical that had never been come across before by anybody, and was unrecognised for a significant period of time. It's fascinating, and that is that. I mean, they weren't in cardiac arrest, but they were really, really unwell, and actually took really novel medical interventions to improve their lot, and they both survived. So it can happen. Yeah,
really complicated.
Yeah.
Especially if you expect that person is going to deteriorate into cardiac arrest, and I think that's happened somewhere more north of here. That this person's taken this, it's definitely going to kill them, but at this point they're still alive. What do we do? And wait for them to go into cardiac arrest and then perform ALS. That's a very, very difficult ethically to balance.
And talking of that, because it's not just in those circumstances, clearly there must be significant psychological risks associated with this kind of work. I mean, I think FEM in general, ambulance work in general, but perhaps specifically FEM and kind of heart operative type stuff. Where do you see the risks, and what has been your experiences and the conversations you've had with other people about the risk of psychological injury as a result of the work you do?
So I think that all pre-hospital emergency and in-hospital personnel will have that shared experience with COVID and what that meant for at the end of your shift. Going home, some people stayed away from their families. So that risk to your family, I think, is a really significant one of what am I going to take home. And there's ways to mitigate that, of course. But I think that's something that we all share. So everybody has a way to relate to, actually, I could end up taking something home that I don't want to. So there's that level of risk to your loved ones. The risks of, actually, this is a hazardous area, which means, there's a chance that I could really come to harm because I'm doing slightly more dangerous things. And, I've signed a contract to say I'm happy to do it. And as long as I've had the training and the Health and Safety Act is, I've been given the appropriate training, the appropriate PPE, etc. And all of the legislation that goes around that, as long as those boxes are ticked, it still means that there is an additional level of risk. So that's something I think to consider for your loved ones as well, if you're going to go into a situation like this. But also, you are more likely to be deployed to these multiple casualty incidents and where there might be survivor's guilt, if there's lots and lots of patients, and if you have to deploy a triage system where that's cut and dry, isn't it, compared to assessing one person at a time and the amount of time and effort that you can put into them. If you've got lots of people, you're moving towards a save the most.
Also with the PPE, isn't it? The stuff that if you didn't need to wear the PPE, you might be able to get a quick cannula in. You can't do that in a gas tight suit. No. I mean, it's impossible. So there's that level of.
It is possible.
Well,
it's not easy. But
that's fair.
We'll probably go to IO.
Exactly.
But there's things that it makes it so much harder to do, which introduces that risk of I would like to do all of these things for all of these people,
and I can't.
But I can't.
Yeah, and I think you could say that to any triage.
And I'm fine because I'm breathing. Whatever I'm breathing is not what you're breathing. And I'm walking out of here, and I can see that these people aren't.
Definitely.
And these people might not, go home, and that is that's a bizarre and kind of unique situation for a person to be in this kind of bubble of security and safety while there's kind of chaos around it. That I can imagine how that could be quite, a powerful.
I certainly think
trigger.
It's similar in the military. Certainly, as the risk or the perceived risk and threat to you as an individual, you're a caregiver, right? But goes up, the psychological impact gets worse. And we see that in the military with PTSD, but it definitely happens in healthcare workers. It happened in COVID. It can happen all the time. People get assaulted in the emergency department, ambulance service workers get assaulted. And that's when you suffer quite severe sort of psychological issues. But that's slightly separate to the mass casualty, horrible, whatever it is, plane crash or chem incident. But I think in HART work, less so in FEM, because most environments I work in are pretty safe, or there might be slightly more unsafe than a hospital, but actually it's a couple of staircases and some heavy weights or whatever, it's not dangerous. Whereas actually a lot of the HART working and the stuff that you guys are trained to do is actually operating in an environment that can kill you. Or that can give you significant harm, because if you breathe the wrong air, you'll get horrible lung injury, or you'll get burn, or you'll get collapsed on, or whatever. So that I definitely think there are levels of this psychological impact that everyone tends to deal with differently, right? So everyone has their own methodology of dealing with it. But I don't know if I know the ambulance service provides sort of generic support to all of its clinicians, but I guess I don't know. Do you get any more tailored care, or do you have any other options of stuff if those things happen, or do you just go to the normal ambulance service sort of trim kind of?
It is exactly the same.
Yeah.
However, we work in teams, and we have to work in teams for a safe system of work. So that's why we have teams of 6, 7, 8. And I think that having a team around you and you have shared experiences is really, really helpful, because I could sit and talk to other friends who are paramedics and they won't have had those situations. So that it's difficult to contextualize. Whereas you can speak to someone on a different team even, and they just understand the types of things that you've gone to. So shared experiences and team working. And I think that we talked about, the structure of teams. And I said, would it be possible for someone to just team jump all the time? And they said no. Because of the nature of the incidents, you need to have almost like a family around you, just to make sure, because you'll all attend those things together, just to make sure that you are under the wing and safety of everybody else. And that's a really lovely, it took some time to get used to when I was new to HART, because I was used to just being on my own and just making decisions by myself and having a crewmate that I could rely on, but not necessarily shoulder some of the burden of responsibility. Whereas everyone's the same. Everyone's a paramedic. Everyone has the shared experience, and we have to debrief quite often because you have all clinicians at the same grade. There's often, I would have done this. But I would have done this.
Debriefing is really important, isn't it?
It's important. It's difficult, but it's necessary. And I think that's. But that team environment is very important, I think, to address some of those psychological difficulties.
Well, that is kind of resonates really strongly with another podcast that we've recorded with Hutch and Luke, and I think that familiarity breeds that ability to be radically honest and open, but also to have that implicit trust, wasn't it?
Psychological safe space.
The psychological safety,
And when you're relying on these people, like I was saying earlier, you are a lookout for your buddy as well. And most of the situations in PPE that we have to utilise, we will always work in pairs. And
so you're literally trusting your life essentially to the person who zips your suit up.
100%, absolutely. If they don't zip up that gas tight suit, then I could be in trouble, like quite significantly, or even your water equipment, water safety equipment. And we joke about it when we're training. You have done my zip up, haven't you? And sometimes sometimes no. No, it is really, really important that we have that trust in each other, that we're going to keep each other safe. And I want to make sure that the person who's next to me is as well trained, or we're both as well trained as each other. And so with that in mind, you get each other through the training and you clarify things with each other, and that's another important thing about debriefing is that clarification of, if at this kind of incident, what should you be doing and what should we be doing is so important to just keep everyone safe. So, aviation situations, they're highly combustible fumes that, even the fire service look a little bit twitchy and nervous and we're thinking, if you're looking nervous, I have no firefighting capability, but I still need to get in there. So I think, team is really important for that safety.
And that feels like a really good place to start to wind this episode brilliant. Up, Dee. So, but before we do end it, we're asking everyone that comes on the podcast to share their golden nugget for what keeps them or has made them sort of successful or happy in what they do. So what would yours be?
I think team working is always going to be, since I've started working in a team in a pre-hospital emergency medicine environment, I think team working is really important, even if it's you and your regular crewmate or the team that you work in or in your wider sort of workspace. It's really, really important to share those experiences and just to stay curious and to keep asking questions and interrogating, and that can expand from, is this the right PPE, to is this the right drug that we're giving, or why do we do this particular intervention? Isn't there something better? That's as a clinician as a whole, right? So we should always be being critical. So staying curious all the time and embedding yourself in the team, whatever that might look like. It might be you and your crewmate, but it could be you and 6, 7, 8 others. So that's my nug.
Yeah.
Thank you very much for sharing your nug. Dee, thank you so much for coming on the podcast today. It's been an absolute pleasure.
Yeah,
Thanks
amazing.
for having me. I hope I haven't bored you to death.
I certainly think you haven't. And thank you very much for listening in again to this episode of Femcast UEA. We hope you've enjoyed it, and we'll see you soon.
Thanks very much.